patient is not going to stay in a fixed position from the planning to the delivery. He's going to go home, he comes back, how many days is lost, and he comes back. So in that process, a lot of changes may happen. So we have to relook at it, re-image it, recheck it, and then do it. So there also imaging comes to the picture. And also after delivering the treatment, you have to see the assessment. There also the imaging comes. So imaging has very, very crucial role. And I would say that it gives 30% of the whole treatment process really relies on the treatment imaging. But of course, we have done really good work in radiotherapy process. Like, we have onboard imaging, onboard CT scan, onboard CBCT coming in the picture. So, but having said that, CT has its own limitation. In the sense, like, CT works on the X-ray attenuation. As it works on the X-ray attenuation, the attenuation of the X-rays, if there is a muscle and a tissue which is having a same kind of a characteristic of beam attenuation, then you are not going to see the difference in the grayscale. So that's what happens in a CT scan. So CT scan can give you very good visualization, but in case of a tissue which is having a similar radiological characteristics, in the sense like the attenuating characteristic of a 120 to 80 kV X-ray, then that's going to be there. You are not going to differentiate that. It's going to give us same grayscale, and you're not going to see the boundaries well clearly. So this is what really happens when you do a CT scan treatment. But when you do a CBCT based treatment delivery, then it's going to be much difficult, because CBCT is not as good as like a CT scan, because CBCT is a cone beam CT as compared with the fan beam CT. The fan beam CT is definitely always better than the cone beam CT because of its own merits and physics of it. So in that case, you are not going to have, because of the scatter component in the cone beam CT, it's going to spoil your image further. So you're not going to see the boundaries better. As you could see in this clear image, as it's an enhanced cone beam CT of a prostate patient, and you are not use, definitely, no doubt, it's very good. But only thing is that, like, inside this area where you want to see the real difference, you cannot do that. That's where the problem comes. This is the area where the MRI can really play a role, because MRI has an advantage of, if you cannot see in T1, we can see in T2. If you cannot see in T2, you can take some special sequences wherein we can really tweak and suppress the muscles, suppress the fat tissue, and then take an image. So in that process, we can really delineate that. And you could see a very good T2 image, which can really show you the anterior rectal wall and posterior bladder wall and the penile bulb and clearly defined prostate lesion. So this is really nice, because this can give an opportunity to do a very versatile and ideal candidate for image-guided radiotherapy with a very good soft tissue contrast. Not only that, MRI being a non-ionizing radiation, it can really do a real-time imaging, because MRI can really do a very fast images, in the sense like you can go up to 8 to 20 megahertz. So in the hertz, so in that case, you can really do a faster imaging. So if you can do a real-time gating, in the sense the real-time gated treatment is quite possible with the MR guided treatments. So not only that, MR also gives another advantage, because you can do a lot of other things, like, you can do a cell density, you can do a microanatomy, you can do a perfusion study, permeability study. So these things, and also you can find out a diffusion weighted imaging and find out the areas where the tumors are hypoxic, where the tumors are very less crowded, where it's really give you a lot of opportunities to find out and study these tumors. And also it opens the door for a biomarker using MRI during the treatment. So that's also another area. And also now, previously when MRI based papers, if you look at it, it was only trying to match the CBCT, but over a period nowadays they are showing very clearly they are doing a superior over the conventional way of treatments. I'll come to that in the last few minutes of this presentation. So what you can see, this is what you can see in MR LINAC. It's so nice. The quality of the image is so good. You can do a real time. You can see a gated treatment. You can see the motion of the tumor. You can see the motion of other critical structures. So this is going to be really a very useful tool for the treatment. Not only that, is there any other advantage you get? Yes, no doubt on that. If you are going to treat a 60 cc prostate, and if you're going to give a 5 mm margin, the PTV is going to be 106 cc. Please note that 106 cc is the area you treat, but the clinician would like to treat only 60 cc. You really do almost close to double, or almost 90% of what you want to treat. You add that 90% extra volume and treat the patient. So it's quite a lot area we treat. And if you look at the 10 mm expansion, it's going to be 120 cc. It's going to be a really huge one. So any reduction in the margin can definitely reduce the toxicity, and also reduce gives the advantage for the patient with a better quality of life. So in that process, MRI can be a way forward because you are able to see it so well and you can get it. So in that case, the advantage of having a very high resolution image, and if you can have a very high less latency, and if you can get it, and if you have some biological imaging, why not? That's a way to go forward because we can really do a very good treatment in that process. So to put it in a nutshell of my first 5 6 slides, where MRI as an onboard imaging is ideal because it uses no ionizing radiation, very good soft tissue contrast, capable of doing a very real-time imaging tracking, and also better suitable for gated treatments. No doubt on that. But how do we do that? It almost takes 20 years for the company to come out with some kind of a technology like this, because the reason being that if you have an MRI and a linear accelerator are a south pole and north pole, because MRI will really disturb your radiotherapy system, because we know that accelerator uses high energy electrons which accelerates electrons and be made to hit the target, and X-rays are produced. And electrons being a charged particle is going to be not going to work well with the MRI environment. So that's going to be a big problem. So beam generation is the issue, and also the beam penetration, because the beam has to penetrate through the cryostat and then pass the MRI and then deliver to the patient. So that's going to be an issue. Then when it passes through the rheostat, it's going to create a lot of scatter. That's going to be another issue for the MRI. And also when we know that ninth standard physics, whenever a charged particle goes into the magnetic field, it's going to tend to turn towards one side. So that's a Lorentz force which is acting on the electrons, which are also going to create a problem. Not only that, how about radiotherapy on MRI? Of course, MRI is going to listen to the RF radiation from your body protons, which is very, very minute signal, whereas radiotherapy is a big RF generator, because you have a magnetron, you have a klystron, you have the waveguide, so many things sitting there that can really create a lot of RF noise, which can really disturb your magnetic field, and it's going to completely interfere with the RF radiation. So these are the things which we have to keep in mind when you go for MR-LINAC. So starting with the bunker, the MR-LINAC bunker is like a little different than the conventional. Of course, the thickness of the bunker remains same because it's just a 6 MB or a 7 MB accelerator. But only thing is that there are some changes. Whereas we define the bunker into two areas inside the bunker, where we call it as a mission room. We have a treatment room. The mission room contains the linear accelerator. The treatment room contains the patient couch, and the MRI. There is some new room called technical room, which is completely outside the mission room, because the reason being that MRI mission cannot be kept inside the LINAC, because the gradient amplifiers, which amplifies very, very minute signals, gets very much sensitive to high energy X-ray scatters. So the semiconductor which is there in the gradient amplifiers does not work well with the high energy X-ray scatters. So these things has to be moved out. So in that process, they moved a lot of components from the inside room to outside, so that the inside room looks clean and neat, and at the same time you can do a really good job outside. So you have a separate technical room either on the top of the bunker or on the side of the bunker, depending on the design. And you have the console, where you need a bigger console, because you have every day, every patient, you have a physicist, radiation oncologist, and technologist to be there, because the technologist sets the patient and comes out, and the physicist start the planning, and then the radiation oncologist does the contouring, and the physicist does the planning, and then finally the technologist treats the patient. So every day you have to have this thing. So you need to have a little larger, bigger room than compared to the conventional one. And also another big factor for the MRI construction bunker point of view is that, like, the MRI is a single piece, and the size of the MRI is 2.5 meters. So in diameter. So if you're going to have a MRI LINAC, you cannot take the machine inside through the bunker, because the bunker is never of 2.5 meter. You may have a door of 2.5 meter, but never the bunker maze wall width is never the 2.5 meter, because nobody does that, because it's a waste of space. So in that case, what you can do is that you don't have to construct this particular wall, and then you take the MRI in, and then you start constructing this wall. So this is a little different than what you do with the conventional way of doing treatments. Another thing is that, like, the system, the bunker also has one more thing, is that it has got a big pit, because it's a 1 meter pit, because it's quite a big lengthy bunker. The height is almost 4.5 meter from the lowest ground level. So quite a higher level bunker, but it really works well, because that only fits and makes the system well. And please remember one thing is that, like, it's a two missions. It's an MRI and a LINAC. So it's a two missions sharing one isocenter. So in that process, we cannot take neither of this mission as a reference, because one mission is depending on the other mission. So in that case, what they have done is that like they have taken the room dimension as the fixed point from where the isocenter is always fixed. So in any LINAC, you go to any MR LINAC center, the corner of the room is taken as a reference, and the isocenter is always at a finite distance from there. So that's the reason when you go to you see MR LINAC in anywhere in the world, it looks similarly the same, because it's going to be the same, because you have the MRI RF gauge also, it needs to be built in. So you cannot customize MR LINAC for your own bunker dimension. It's going to be always a fixed worldwide, whichever number of sites you see that. It's almost some 100, 120 installations are there, 100 installations are already there. So those people always have the similar one than others. Okay, just to summarize, the mission has a 7 MB LINAC, 7 MB linear accelerated. It's a flattening filter free beam, and it has got a 1.5 Tesla MRI. Which has got enhanced simultaneous delivery of MRI and the beam, like not like conventional CBCT based mission, where CBCT is on, LINAC will not be on. When the LINAC is on, CBCT will not be on. Not like that. Here we can have an MRI and the LINAC together on and work on that. And if you look at the layout, I have already told you the room layout has a control room, technical room, machine room, and treatment room. Okay, so this already we have seen that it has got a watt-meter. It's a big 1 meter pit through which the LINAC goes down and deliver the dose, whereas this is the pit for the couch, and the MRI stands on this small square here. So two legs here and 2 legs here, and it does that. I'll show you how it does that actually. So this is a typical layout, a schematic picture of the Unity LINAC. So this is the area where the linear accelerator is kept, and this is the area where the MRI is there, and this is where the patient lies down. So this U-cut is the area where I call it as a machine room. This entire thing is a treatment room, and we already discussed about the technical room and the console. So coming to the LINAC part, the LINAC is a 7 MB flattening filter free beam. It's a single standing wave, no electrodes, no high energy. So which is coupled with the MRI machine and attached to that, but not directly connected to that. But they together work close by and then deliver the required dose. So the key features: the magnetic field is 1.5 Tesla MRI. It is equivalent to an Ingenia Philips MRI mission, and the source to axis distance is 143, because the reason being that you have the MRI there. So above the MRI is that wheel is there. In that wheel you have the LINAC. So this is a LINAC and this is the MRI. We are seeing the cross section and the patient lies down here. The MRI is a split magnet design where there is an opening there. Through that opening, because you have the gradient coils there, these coils, body coils there, these coils are can attenuate the beam. So we have to have a gap through which a window through which the X-rays can pass through and deliver the dose at the same time without losing the homogeneity of the magnet in this area. So that's again a biggest challenge, but they could really do it. And the field size you get is 57.4 by 22 centimeters. Okay, and the mission room is located in the bunker, and this is how it looks like. You have the RF gauge, and outside the RF gauge is the LINAC, inside the RF gauge is the MRI. So the pink one is the MRI, and the outer ring, gantry ring, is where the entire LINAC is kept. So the LINAC goes around the MRI and delivers the dose. The MRI pink color has a small slot window through which the radiation is being delivered to the patient. So the beam shaping is done similar to what we have in a conventional LINAC, where you have the X-ray and then you have the target, and then the MLC is there to collimate the primary collimator, and then the MLC, and then you have the MV imaging where the detectors are having the images, and you have the water conditioning system, which I'll come to that, how it works and all those things actually. So this is how the ring looks like. This is where the gantry ring looks like. And the advantage being here is that like it's a bi-directional motion, in the sense like the gantry can rotate continuous direction, and it also come back in the other direction. In a conventional LINAC, you rotate and then you come back. You cannot rotate continuously, but because here the advantage is that the system uses slip ring technology, so you can really rotate and deliver the dose continuously, like similar to what you have in a diagnostic CT scanner. So, and also because it's a ring gantry, your isocenter accuracy is so good. It's almost 0.5 mm. In our case, it's 0.32 mm. So it's quite accurate, and it's very nice. This is what I was talking, the slip ring technology. So through the slip ring technology, the advantage being that the gantry does not have the cables coming there, so which can get twisted. It is not possible, because Here, the advantage is that the system can transfer the energy through the slip ring technology so that it can keep on continuously rotating it. So that's a very nice design to do that. And looking at the LINAC, the whole LINAC, what you see in a conventional machine is being packed in one small area of the segment of the ring where, this is where it starts. You have the modulator is so small and your waveguide and you have the accelerating structure and then you deliver the dose. So that's quite short, at the same time does a very good job. Then you have the RF modulator, this RF modulator, you have the magnetron here, then the RF circulator, and then the sensor, similar to what you have in a conventional linear accelerator. But only the thing is that you should always remember that there is a magnetic field which is 15,000 Gauss. The MRI is you cannot even take a small safety pin inside MR. So how can you have a linear accelerator? So we have to find a different way. So these people have done a very good job by sealing the entire accelerator inside a mu metal, because mu metal has the highest magnetic permeability, so it can really bend your magnetic field. So the advantage is that like the 15,000 Gauss at the level of isocenter gets reduced at the level of accelerator to 1 to 2 Gauss. So it's really wonderful because the earth magnetic field, whatever we are right now sitting, is almost 0.625 to 1 Gauss. So we will be as good as like that, so that the electrons can get accelerated and doesn't get deviated because of the MRI presence there. But all this is done with the help of a mu metal, which is completely sealing the entire accelerator from the magnetic field. Another thing you have to note down here is that the collimator does not rotate. So it's a zero column. The collimator cannot be rotated because the space is so tight. So the system cannot rotate the collimator. The direction of the MLC is always along the bore, which is unlikely than the conventional, where you have it is in the X direction, whereas it's in the Y direction. No light field because there is a bore, so you cannot see the light field. So you have to work with the MV image. And you have the number of leaves 160, and the MLC wheel width is 7.2 mm. Although it's a 5 mm width, but the source to axis distance is 143.2 centimeters. So that's the reason why it becomes 7.2. And coming to the chamber design, the quadrant chamber electrometer, which is there in the machine to monitor the output flatness symmetry of the machine, is being little different because it contains 3 copper covered ceramic plates, and which is helium filled, which is unlikely compared to the conventional LINAC, where we are most likely air filled, and it is hermetically sealed in varying accelerators, and it is open to the atmosphere from the point of view. But still, this particular chamber is liquid filled, and they filled it with helium. The reason being that, like, because the accelerator is kept at 143.2 centimeters, the accelerator needs to pump in a lot of energy to get the dose rate at a considerable clinically usable dose rate at the level of isocenter. So in order to deliver to that level, the system has to really pump in. So if you take this accelerator and put a conventional LINAC, it will deliver 3,000 to 4,000 mu per minute, which is quite fast. So, but in that level, if you are going to use your conventional ionization chambers, it's going to saturate a lot. So we need to have a better ionization chambers which does not saturate at that dose rate level. So that is where we have the advantage of having this helium-filled ion chambers, which is specially made for MR-LINAC because of the high dose rates. And also, this is again, the accelerator cannot be opened like a normal accelerator. So it has to be opened in a proper way. That's why we have the pit there. So we open the accelerator, we swing out the accelerator and then use it and then do the servicing. It's quite different as compared with the conventional way of doing it. The next one is that like the couch. The couch is also very different compared to the conventional because it's like a couch like similar to an MRI machine. So the couch has got a completely MR compatible components, at the same time very strong components because it has to withstand the patient weight load, and also it goes in the platform because you have a posterior coil which does the MRI imaging. But you don't have to worry because this couch is going to attenuate the beam a lot. So it's going to almost, we'll call it as 15 to 20% attenuation of the beam happens in the couch. So, but we know how to handle this. So we can really do the Monte Carlo of the couch and then model it and then do the dose calculation. So in that case, we can really do a very accurate treatment. So each part of the couch is so well defined, and then we calculate the density, we calculate the values, we have the CT values, we have the electron density values of that. So we always, every patient, we incorporate this and deliver the treatment and calculate the values. The couch is quite strong because it can really withstand up to 227 kilograms, and then it can move in a longitudinal direction, but it cannot neither move lateral nor move the vertical. So the machine cannot, if there is an isocentric error, the machine cannot adjust like what we do in a conventional accelerator, where if there is a 5 or 3 shift in a chronocordial, we just move the couch and do it. No, it's not possible here. So the only way we can do is that we move the beam instead of the couch. So in that process, we have to do every patient a recalculation, retreatment. So it's not like you cannot do like a conventional way of treatment in this machine. Coming to the MRI, this is how this is the entire accelerator. This is the MRI, this green box which is here. The MRI is a split design, as I said. Through this gap only this treatment is done. How is the coils are placed? You have the superconducting coil. You know that it's a electromagnet. So the superconducting coils are kept in a 4-degree Kelvin of helium, liquid helium. So this will make the superconductivity and create the permanent magnetic field without having much of homogeneity. Then you have the gradient coils, which is small magnetic gradients, which creates the small magnetic gradients to create the per mm of the patient tissue, so that we can really create a flux of gradient coil. Then we apply through the system body coil, we apply the RF pulses. These RF pulses, the system gets perturbed. Then you get the anterior and posterior coils, which receive the signals from the patient body. Depending on the amount of hydrogen atoms in the patient body in that area gets perturbed. And then the relaxation also, depending on the material characteristic, they relax either in the transverse or in the T2, and then that in a longitudinal direction with the T1. So that when that we can really capture the values and then reconstruct the MRI images. So that's how we do that. The similar concept is there also here in this machine. But the challenge is that, like, how can you, now we know that mu metal is used so well for the MRI imaging, but only thing is that, like, how do we do when the machine rotates, there is a possibility that the magnetic field can get perturbed. So that can be really managed by adjusting the active magnetic shield by using gradient coils in along the entire linear accelerator slip ring area, whereas we can add these coils so that the rotation of the gantry of the linear accelerator can really create a lot of eddy currents in the MRI magnet, which can indirectly influence your MRI image, can be nullified by creating this adding magnetic sources for the rotating motion, so that we can really get a very good quality image. So that's a real beauty of this machine, where they can really do that. Coming to the accelerating guide, this accelerating guide is a short wave guide with ultra high vacuum, because this wave guide is kept at a very, very high vacuum. By increasing they increase the temperature of the vacuum accelerating guide as such a whole thing, and then they create the vacuum. So that's the reason, like in this machine, if you have a problem with a gun or a target, you cannot replace like a conventional LINAC. Here you have to replace the entire accelerating guide, because the possibility of increasing the temperature and then replacing the gun in a conventional clinical environment is quite unlikely. So it has to be done in a factory. So that's the reason why they do that, actually. And it's also single focusing magnet. So you get the beam, otherwise you don't get the beam. So no steering coils, no focusing coils. So you don't have to worry about the stereo flatness symmetry issues, because you can get, if you get the beam, you get it right. And this is how it looks like, the slip ring technology of the machine. So the slip ring continuously rotates, so you don't have to worry about the cables coming down. This is how it looks like. This is the modulator cabinet of the LINAC, which is, you see in a conventional 2-beam or rubber size. There's a big modulator, which can be, here it's been remodified with the solid state technology. It's a very small, and you have the waveguide. And this is the mu metal, which you can see here. It's completely covering the entire accelerating guide, where the electrons are accelerated and then created the X-ray. So that's nicely designed so that you can do that. And another reason I told you that the collimator cannot be rotated, because the tight is too tight. If you rotate the collimator, there is a possibility that it can hit somewhere. And also it's very risky to do that. So they are not doing that. Here the cooling is also not the outside chiller water comes only to the chiller. and goes back to this area, this chiller. But this chiller is never connected to the machine because the machine continuously rotates. So in that case, the cooling is also, we call it as Wi-Fi cooling, in the sense like the system dissipates all the heat energy to the atmosphere. From the atmosphere, this heat exchanger absorbs the heat and converts the cools down the atmosphere. So that's the beauty of the system. And also the interlock and the data has been transmitted to the Wi-Fi. So really a very high-end sophisticated machine. Coming to the MLC, it's the same similar agility MLC, 5mm MLC, the same way how it works with it. We know that agility works well. We have used so many times, so it's really worked quite good. And this is just to give you a feedback, feel of the pit, such a big pit inside that through which the LINAC rotates, and you have a big crane there which is helping you to. This crane is permanently fixed in the accelerator bunker to move the bigger items of the MRI and the LINAC to fix it in case of there is an emergency servicing to be done. But as I said, so the superconducting coil helium is at 4 °K helium, liquefied helium. But there is always a possibility that if the helium started boiling off, it can really come out and come to the clinical room atmosphere, and then can really deplete the oxygen. So people inside working may know that the oxygen is getting depleted, and they may faint and may get into trouble. So in that case, you need to quench you need to remove the helium. So there is a quench pipe. You might have seen in a conventional MRI image, there is a big quench pipe. Similarly, we also have a quench pipe which connected to the cold gun diode of the MRI. So in case there is an emergency, this quench pipe can take the liquid helium to outside the atmosphere, just 7 meters above the ground level, so that it goes out. Helium being a light gas, it never stays back in the down, it just goes up in the air, which we have seen in our small kid, helium balloons. With that, we can see that. And also, this machine has a beam stopper, so it's a quite good thick beam stopper, so it can really primarily stop the beam. So in that case, the primary beam which comes out of the machine is only 5% of their initial primary value, so that's quite less. So that makes really advantages, because your bunker can be little thinner, and also the leakage around the bunker is very, very less as compared to the conventional LINAC. And also, as I said, the machine has it's a two independent machines. So you have the MRI here and you have the LINAC there. The MRI is fixed on the floor and the LINAC goes around the LINAC. Sorry, something is
टिकट आ गया क्या उसका? टिकट आ गया तब मिल जाएगा.
Can I continue or hello? Are you able to hear me? There is some cross talking is coming. Hello.
I think sir, someone's mic is on. You can continue,
okay.
please.
Okay, I'll continue. Okay. So this is how the real pit looks like, and this is for the couch, and this is for the LINAC, and you have first the gantry ring comes and they get fixed onto the pit, as you could see here, and then you have the gantry ring fixation components comes there, so they get fixed up, and you have the MRI. It comes as a single piece. So this MRI goes and directly fits into this one. As you could see, that this is the pit wherein the LINAC is there, and the MRI goes here and puts 2 legs here and 2 legs here, and then gets attached there. And this is how it looks like. So you have the MRI inside and you have the LINAC. So the MRI does the MRI and the LINAC does its work by rotating around the patient. So quite a good, nice design, but it really works well. And this is how the RF gauge, because the RF gauge prevents the RF radiation from external areas reaching the MRI, so that the MRI can listen to the RF radiation from your body protons. So that's advantage of that. And we also tested our own, the effect of LINAC on MRI imaging is quite less. It's nothing feeble. I think there are some good papers also which show that it really works well. How about accuracy of the LINAC? The LINAC accuracy is also, geometric accuracy is very good because it's a ring gantry system. So the EP, if you take the MV image and see that when you plan and then deliver with a bony anatomy, if you try to match that, it's quite very, very tight. It's almost 0.3 mm accuracy. But having said that, the Lorentz force is always there, because the electrons are going to get deflected when you undergo some, when you put them in a magnetic field. So of course we isolated the linear accelerator from the magnetic field, but there is another challenge comes, because when the high energy photon hits the patient, Inside the patient, the delivery is through electrons, because the photon transfer all this energy to the electrons, and the electrons gets the energy and then travel to some distance in the patient's body, and then deliver the dose at a particular point. So the electrons, when it gets generated, they tend to get to know, because the Lorentz force can act on it. So that also has to be incorporated. Like what happens if if you look at the effect of magnetic field on a charged particle, large angle scattering and of a mean free path with when you have a low magnetic field, the electrons can scatter many times before they spin. But when you have a high magnetic field, they can spin around and then they scatter. So in that case, they just turn and then deliver the dose. So what really happens is that, like, the electrons which are coming out of the patient can turn back and deliver the dose to the surface, posterior surface. So this can really increase your exit dose and also can really play a major role. But we are not going to treat in MR, LINAC and APPA field. No, we are going to treat the patient with IMRT treatments. And we have multiple fields. When you take a multiple field, this effect can become very negligible. And also, we are not going to treat the posterior surface of the patient body. We are going to treat the deep-seated tumors. So in that case, this effect will not have a much on the clinical outcome. If you look at the characteristics, the beam penumbra increases by 1 mm because of the magnetic field. The buildup decreases by 4 to 5 mm. Field shifts by 0.7 mm because of the Lorentz force, and the field width is always remains same. It does not get affected. But if you look at the dose distribution, as you could see that the penumbra, as the PDD gets shallower, so you get the Dmax shifted towards the surface. So, but the electron contamination is not much, but still you have the shifting of that because of the Falting filter free beam as well as the MRI effect, and also the penetration is lesser as compared with the conventional beam. And also another point you have to note down is that, like, the electrons which are coming out of the collimator also may get pulled towards the magnetic field. So in that case, what happens when you're going to treat a patient with a brain or head and neck, there is a possibility that you may deliver some dose from the electrons which are coming out and hit the patient's chest. So what normally we do is that when you treat like this, when there is a situation coming like this, which we keep some wax material here so that it just gets absorbed there, because a small amount of 5 mm to 10 mm max material in the patient close to the patient area, outside the area, will absorb these electrons so that it unnecessarily does not give dose to the patient. So these are the certain things which we have to be careful when we do a MRI based treatment. And also the Dmax is much stable in the magnetic field as a function of field size. So it's going to be because due to lack of variation of electron contamination between the field sizes, it's going to be the same. So it does not change much among the field size values. But please remember that because of the Lorentz force, the field is get shifted towards one side. So we see a tilt in the field, and this will really predominantly more and makes the field very asymmetric. So when you do a flatness symmetry check for a MRI LINAC, the 10 by 10 may be a little okay, but when you go for 5 by 5 and 3 by 3 and 2 by 2, it becomes very asymmetric. But if you are able to reproduce that asymmetry, then it's not a problem. Because initially, maybe people may have a physicist may have an issue, like, because we tend to see a very flat beam, we tend to see a very symmetric beam. But only thing is that, like, that works well, but here it doesn't work well because you have the Lorentz force coming there. So in that case, the fields are very asymmetric. But if you are able to reproduce that, then you can really do a Monte Carlo simulation of the fields, and then you can use these things for the dose calculation. So whatever happens on the phantom is going to be the answer on the patient also. So you can really resimulate it and do it again. No, because when the flatting filter free beam came, people were telling, oh, it's an unflat beam, I cannot use it. How can you use an unflat beam? But we have modeled it so well, and then we used it, and then we are doing a lot of SBRT on that. Similarly, this beam also asymmetric, but maybe people who work in a conventional LINAC may not like it. They say that what is this asymmetric field? But if you're able to reproduce it and then you can measure that characteristic of that particular beam, then you can very well use it and for the clinical application. How about the leakage? The leakage is quite less because we did quite a lot of measurement, and we could find out the photon leakage in the patient plane is very less as compared to the conventional LINAC. But having said that, although it's a nice machine, so many things are there, we want to be very sure, because we don't want to over enthusiastically take the machine and then start using it, because any new technology may be very exciting for the users, but it should do the job properly, and at least it should not deteriorate what we do with the conventional LINACs. So in that process, what we did, we took all the parameters and we just tried to compare with the global institutes who are already using the LINAC, and we compared the 14 institutes, and we could really see that we are within 1 to 2% of their data. So that then it means that we are not very far away. Coming to the quality assurance, of course, the machine needs a lot of QA tools, and especially MRI. You need to check your BGA homogeneity. You have to see the image orientation, gradient fidelity, flip angle accuracy, spurious noise, PAQT, and ACR. All these things you have to do, but it's a laborious work. Physics have a lot of work to do that, but really works well because it helps the patient. So in that process, we can really take that challenge and do that. So this is again one of the nice phantom where we can check the geometric accuracy of the MRI, because we are going to treat MRI, use the MRI and treat the patient, right? So in that case, your geometric accuracy of the MRI matters a lot. So what we do, we have this phantom through which we try to do similar, we image the MRI phantom and see that we know the finite size, what is the values, what is the inter point distance between the each capsules, MRI visible capsules. But then we measure it and then we see that whether it is matching with the original one. And we could really see that if your diameter is going more than 40 centimeters, then only the error is coming 2 mm. That also can be incorporated, but less than that, it's going to be less than 1 mm. So we can really believe the system and do it, and you have quite a good amount of dosimetry to be checked. And also another thing is that apart from radiation safety, MR safety is also plays a major role. So you have to have the proper MRI safety, because you cannot just like that walk into a MR LINAC treatment just without having any proper checking, because there is always a possibility that you can really spoil a 100 crore machine just like that by just bringing a metallic item into it. So you have to be very careful. So we create zone 1, zone 2, zone 3, zone 4. Zone 1 is simple now, anybody can be there. Zone 2 is a checking zone. Zone 3 is a place where only people who are trained in MRI or MRI safety, or the patients who are already scanned are already there. And zone 4 is the area where you have the magnet is there, so you cannot go unless otherwise you are trained or unless otherwise you are scanned for any metallic implants. So we have like our airport, we have the scanner. So we check every patient when they go in, we check it. Everybody who goes in, every visitor who comes here, we check it with that, and then we make sure that everything is going fine without any problem, because there is a possibility that anybody who is not supposed to go in went inside. We know that MRI accidents has happened. People got stuck with the oxygen cylinder and the MRI machine, and it's very painful and it's very difficult to remove the patient from that. It's very dangerous. And also, not only radiation safety, not only MR safety, but also helium safety, because as I said, helium is a colorless, odorless, tasteless, poisonous gas. It can really deplete your oxygen, so it can be really dangerous. So you have to be very careful when you do when you check it with that. So there is a possibility that we have the emergency, apart from the conventional emergency buttons, we have the emergency button for the MRI, which is called emergency quenching, to release the MRI in case the patient gets stuck in between, or the technologist gets stuck between a big metallic object and the MRI machine. So that can really only in case of life-saving situations we just use this machine for that one. This is how they went the helium. But of course, being very expensive now with the war going on, it's very, very expensive. You do one quenching, you lose 1.5 crore of machine, 1.5 crore of rupees. So that's very, very expensive to do these kind of works. And so that in that process, we have to be very careful. Not only the helium is costly, but also helium level matters a lot, because Gantt is rotating around the MRI rheostat, and if your helium level keep on changing, then the helium is going to attenuate in different way. So you have to be very careful. So you have to check every day the helium level and make sure that the helium doesn't get boiled off, so that your not only it does not affect the dosimetric characteristics, but also should not deplete the oxygen inside the room. Not only that, you have to check the patient for the implants, equipment. So it's very different mission, because right from the technology's point of view, physics point of view, radiation point of view, it's quite a laborious one, but it's worth doing it, because at the end of the day, I'll show you how it really benefits the patient. But you have to be, the technologist has to be very careful. Every patient has to undergo a MRI safe checking, but also not only that, not only a one day, they have to do it for the 30 days, because any day suddenly patient may go for some kind of implant, some kind of a dental work, or some kind of or they may carry something else, or they may having some religious metallic items. So all these things, so every day when they come for a treatment, we need to check that. So we have a separate checklist. The technologists check it religiously to make sure that whether he has undergone any cardiac procedure, whether he got a pacemaker, so any implant is there, any metallic parts are there. So all these things we check it, we do that. So this is also another, like, have radiation safety, MR safety, helium safety, and then the patient safety is also very important. So it creates a lot of safety things, but it has to, because at the end of the day, you want to do a proper job. Coming to the quality assurance, of course, there is an end-to-end QA. You have to do that. You have to make sure that it's a similar CRS phantom where you have liver, lung, MR compatible items. You have the opportunity to put the chamber, so you can move the chamber and do an MRI and see that and plan it and deliver the dose. So that can be really checked properly, right? So, but when you come to the observed dosimetry, we know that observed dosimetry, we have the KQ factor, which is responsible for the characteristics, because most of the chambers are calibrated in cobalt 60, but we are going to treat in a 6 MV LINAC. So the characteristics of the back chamber, the response of the chamber to the cobalt 60 beam and the 6 MV beam may be different. So to account that, we have a K0 factor. But now the quality factor, whichever energy you're using, you use that KQ-Q0. But now we have the magnetic field coming there, so we need to have one more factor called KB factor. There is the KB factor which is responsible for the magnetic field. So that also you need to incorporate to do the dosimetry. But also you have to be very careful. We know that Lorentz force can act on the electrons which are produced inside the chamber due to the high energy X-rays, creating an ionization inside the chamber. So these electrons also tend to move in direction. So we have to be very careful when pushing the chamber. If the chambers are parallel to the MRI, that's very nice. We can really, the correction factors are quite less. If you're going to put it across the this one, then the electrons are going to go in the direction along the axis of the chamber. So in that case, the perturbation factor or the factor which you are going to do a dosimetry can be really as good as like 4 to 5%. So you have to be very careful when you put the chamber and at the same time calibrate it, and also make sure that you apply the correction factors properly to do the dosimetry. How about isocenter? You have to be very careful in this side. They're going to have two machines. One is MRI, another one is a LINAC. Both are not sharing the same isocenter. Both have its own isocenter, but they are finite distance from each other, because you can have the isocenter very close to each other, but they cannot make it same place, because to have it the same dot or a same point for both the machines, then the both machine has to be integrated, which is not possible because MRI creates a magnetic field where LINAC does not like the magnetic field. So in that case, you have to create an environment where they share the isocenter but is close to each other. But these values, which are the difference between the isocenter of the MRI and the isocenter of the LINAC, can be incorporated in your planning system. So whenever an image is taken, automatically system applies for this correction, and then you can do the delivery of the treatment. So that's nice. So these parameters we used to check every weekly and make sure that the MR MB isocenter parameters are very well matched, and at the same time the MB isocenter, which is 0.3 M, 4 mm in our case, is also matches to what we have kept at the commissioning level. Coming to the patient-specific quality assurance is almost similar to what we do in a conventional LINAC, but only thing, important point you should remember is that like the dosimetric equipment should not, whatever you're using in a conventional LINAC cannot be just away taken into the MRI machine, because it has to be MRI conditional or MR compatible. MRI conditional, at least you can use it. If it is not MRI conditional, you cannot take it here, because if you take it inside, the phantom can really get stuck with the machine and you will lose the phantom as well as you get some part of the machine. So you have to be very careful in what chambers, what electrometers, what phantoms, or what should be allowed inside the MRI room, and that should be used for that. So we have an MRI compatible patient-specific quality assurance tools, which you use it for that and do a dose calculation for a planar and absolute dose rate. This is how the machine looks like. You can see that very nice, beautiful machine where you can, with a good interiors, you can really do that. Okay, coming to the clinical application, this is the quality of the image you get with this machine. It's so nice because you see that the quality of this S.M.L vesicles are clearly seen. You have the rectum, you have the bladder, you can see the ventral wall, rectal wall. Not only that, inside the prostate, you can see the intraprostatic lesion. So that's fantastic, because we can see inside prostatic lesion, inside the tumor, where we can see which part of the tumor is crowded, which part of the tumor is not crowded. We can really do that. So this is image quality we get in 2 minutes MRI. So the 2 minutes MRI is the biggest advantage here, because the system uses the compression technique with the K-space reconstruction, alternate K-space reconstruction by doing a Fourier transformer. So this really makes the life very easy for us, because you do a CBCT, conventional CBCT 1 minute, whereas you do a 2 minute MRI. But if you get an image quality like this, why not? We can use it, because we can plan and deliver the dose. And every day there is always a change in the tumor position, target position, critical structure. So So all these things can be really incorporated well. Where you, as you could see here, that there is a acoustic schwannoma, the tumor, which which we never see in a CBCT mission, where we can really see this mission tumor so neatly, clearly identified. The advantage being is that, like, some most of these acoustic schwannoma the hearing is preserved. So if your hearing is preserved, if you can really find out the tumor so well precisely, and then you plan on that particular day, on that particular anatomy, or plan of the day, and then deliver the dose and make sure that the cochlear dose, depending on the number of fraction, if it is a single fraction, we keep it less than 4.5 gray. If it is a 5 fraction, we keep it less than 16 gray. So we mostly keep it at 14 gray. So in that case, we can really preserve the patient's hearing capability, at the same time deliver the dose, and you don't have to give a margin in that area. So you can really do a very good plan on this. So that's definitely a big advantage. This is again a nice another AVM case where most of the time AVM patients are embolized. So as they are embolized, they are not seen neither in the CT nor in CBCT. It's absolutely impossible, because a lot of artifacts you will never be able to see the nidus, where you can really see the nidus so well here and then plan and treat. So definitely this mission has advantage not only in the cancer but also in the non-malignant disease. This is again a typical patient treatment, middle of the treatment, as you could see the beautiful response happening. So we can really reduce critical structures or target volumes, and then again save more of critical structures, so we can avoid unnecessary toxicity to the patient. This is again a typical example where most of the time we thought that whenever we treat the breast patient, we always think that the breast moves, but the breast doesn't move. It's a heart only which is coming in the field and deliver the dose. So we have to be very careful. This is a live image during the patient treatment, where you could really recontour the heart, and then replan it, and then make sure that the heart is out of the field, because most of the cancer breast patients, they survive a lot. So when they survive a lot, they tend to get a cardiac, because already they received a chemotherapy drug which is cardiotoxic, and at the same time radiotherapy also can add to that. So we can really avoid this by doing a real-time imaging of this and then deliver. Not only that, in breast cases, what we can do is that, like, if you're going to do a partial breast irradiation, we can do really wonderful job, because we can do a 5 fraction treatment by just drawing only a cavity of the breast with 1 centimeter margin, and then deliver a very high dose to that without giving any dose to the other structure. So that's also possible. This is again a very ideal case where you could see that the pancreatic tumors, where MR-LINAC has shown survival benefit compared to conventional LINAC treatments, because it has shown 21 months survival benefit as compared to that. So that's definitely possible only because you are able to see the tumor. So because CT is like this, where MRI you can see it so clearly, so you can really do. And if you look at the CBCT, it is much worse, which can be really very well seen in an MRI image, and you can really plan well very nicely, and then deliver the dose, required dose to the patient, without giving any dose to not much of dose to the adjacent structures, like duodenum or the bowels or stomach, which comes during the treatment, which can really track, deliver, and do that. This is again another area where the MR guided treatments can be really very, very useful. As you could see that the prostatic tumors there is a clear cut study which shows that if you are going to decrease the dose to the urethral toxicity is going to be lesser, because most of these patients are elderly patients. They already have some kind of urinary issues, and if you are going to have radiotherapy, SBRT given, and your urinary incontinence may increase. So what you can do is that in MRI you can see the urethra, so you draw the urethra and then you deliver lesser dose to the urethra and make sure that your urethra is preserved, so you can really help this patient at the same time cure from the disease. So again, this again a nice study where they can really show that if you can 1 grade reduction in the urethra can really reduce 5% reduction in the toxicity. So that's definitely a nice area where MR-LINAC can really do a very good job by showing these areas and planning an adaptive and treatment patient. Like this we do it in our center also, where we draw the urethra and then deliver it to that. So as you could see that the urethral dose is much better controlled with the daily adaptation as compared with the conventional CBCT. We will never be able to see the urethra. Even CT scan is very difficult to see, whereas in MRI we can really see it so well. We can really reduce the toxicity from the urethral side. This again our own patient. As you could see that this is the urethra where it is shown. We can see the blue color, it's slightly lesser dose, but it is not very less dose, because we don't want to underdose the urethra, but we don't want to at the same time overdose the urethra also. So you can draw everyday urethra and match that, plan again, and then deliver the dose. This is unbelievable for a conventional way of treating the prostatic tumors, which we can really do that. Not only that, inside the prostate, we can really do an intraprostatic lesion. We can do during the first day of the treatment or during the treatment day, we can do an additional diffusion weighted imaging and then see to that which part of the area the ADC values are very high, and we can see the intraprostatic lesion and contour that intraprostatic lesion and then deliver higher dose to the intraprostatic lesion and also reduce the dose to the urethra, at the same time deliver the required dose to the entire target. So this is definitely very nice because it can really help the patient at the same time have a better tumor control in terms of intraprostatic lesion post, and also better quality of life or with the help of reducing the dose to the urethra and reduce the dose to the penile bulb. So all these things matters a lot because it can really add value to the patient. Not only that, during the treatment, we can really track the patient. As you could see, even if there is a gas come system, automatically you see the prostate moving so much, then immediately system tracks and stops the deliver and then do the treatment. So that is also possible. And this is the quality of the image we get with this machine, where very high quality, which it is impossible for us even to get with the CT scan image. So where we are getting on an everyday basis on a treatment day image. So that's definitely nice. Not only that, this machine goes to the next level where we can do a free breathing, we can do a breath hold, we can do a exceptional gating treatment. So we can ask the patient to hold the breath and deliver the treatment. So that is also possible. That makes really nice because you can, for a pancreatic tumors, you can do an XL treatment. For a lung and liver SBRT, you can do a breath hold treatment. And then in some other patients where you can do just monitor it and make sure that it does not go. Like a prostate, you can just tell the system to monitor it. The bladder filling comes and pushes the prostate, then stop the treatment. So automatically we can do those things actually. This is again the real key capabilities, like we call it as anatomical position monitoring system, can monitor the tumor. The biggest advantage, people always say that, no, we have a cyberknife. Cyberknife also does the same. But cyberknife does only go with the fiducials. If the fiducials are kept in the wrong position, you track the wrong area. Not only that, if the tumor, suppose let us assume that the fiducials are kept in the tumor, how about the critical structures? Suppose you want to save how much amount of critical structure is coming on a particular day into the tumor. No, it is impossible to see in a cyberknife because they don't have a CPCT. So we can, but whereas in MRI LINAC, we can really do a tracking of not only the target, but also tracking of the critical structures. So we can track the critical structures, we can see the critical structures, and we can make sure that the critical structures are getting lesser dose, and also the target is getting the real dose and then deliver the dose. This is quite amazing because this is like, this is a typical case where I do an SBRT treatment where we can see that the patient is holding the breath, and then now this patient started breathing. So when he started breathing, the system holds, there's an orange line comes, it means the beam is on, not. Whenever it comes within that particular area of green line, the system delivers a tumor. So that's amazing. This is the quality of treatment we do in our own patient. This is our own patient where we treated like this in our delivery. This is the quality of the image where you could really see the boundary. You can see that very close to structures you have the tumor. So we have to deliver a very high dose here, at the same time reduce dose to that. So when you create such a high gradients, you have to be very precise in creating when you deliver the dose. That also has to be really we have to be very careful when we do that. This is again another case where breath hold is going on, whereas we can really do a cardiac imaging can be really tracked and deliver the dose actually. So this also our own patient where we can see the small tumor can be tracked in the lung and deliver the dose to your volume. So this much small volume can be very well treated in this machine. This is again another example similar to that. And you have the pancreatic tumors, which are also can be very well. If the patient moves, the system automatically stops the beam and delivers. So that's really beautiful, where we can really, the system response is so good, and even the latency of the machine is so less that, like, APM recommends the latency between the MR LINAC and the LINAC should be less than 300 milliseconds, whereas in our case it's less than 150 milliseconds, which almost, to be precise, it's 126 milliseconds, because the advantage is that, like, the system has the AA capability where what it does is that before we treat the patient, system takes 1 minute of reading the patient images, patient respiration pattern, everything, and understand the way patient breathes and the tumor moves, and then accordingly counter the motion artifacts, so motion of the patient, and predict the tumor where it can come, then accordingly do that. That makes really useful for the system to get the latency so less in that. This again another patient where we want to treat the upper pole of the kidney, and where we could really match only that part and then deliver the dose to that. So this is a precision with which the system can really, whenever the system comes, tumor comes here, the system delivers. Where you can see all the structures around that. You can see the coronal, sagittal, and transverse. So you can use you can get a clear idea of what is happening in the patient, and then accordingly deliver the tumor dose. This is again just want to give you the real feedback of the patient. Like, our one of the patient we have treated, patient having only one kidney, and even in that kidney there is also a tumor. So we have to save the kidney and then do the delivery. So we did that. It's last 2 years follow up. The patient is doing very fine. At the same time, kidney function is also working, and we deliver SBRT to the treatment, and the tumor responded so well. This is quite possible in these kind of missions. It's again another clinical result of our own patient, where before treatment and then before treatment and after treatment, the response is so good with the area where we treated. Because the machine has the capability of the diffusion weighted imaging, we can really do a diffusion weighted imaging and find out internal tumor characteristics, like how much tumor is crowded. We can just measure the Brownian movement of the water in the tumor area, and then you can plan the dose distribution and then deliver the dose with that. Now, there are nice studies which show that if you can really do a apparent diffusion coefficient of the tumor area and then take the mean value, that can really be a good biological biomarker. It can really predict that. This is a nice study where they have really showed that ADC value can really significantly improve the local control as compared with the conventional model of way of treating it. Actually, this is again a nice GPM study where they have really showed that the diffusion weighted imaging can on a MR-LINAC can clearly tell you whether this patient is going to respond to the treatment or is not going to respond to treatment. So accordingly, you can increase the dose, or you can really balance the situation and then deliver the required dose. Actually, again, in the cervical cancer, it is clearly proved that ADC value can really be a very good prognostic factor, especially adenocarcinoma of say cervix, where we can really find out if the ADC values are changing, and it can really tell you that whether you need to have this patient might recur or may not recur after brachytherapy. Also, this opens a new door of research and innovation. We can do an oxygen-enhanced MR-LINAC treatment. We also do some patients with intact head and neck tumors. If you have more oxygen, the oxygen radicals can really increase the tumor cell kill. So automatically, the patient, if you can give during the treatment of MR-LINAC, if you give oxygen, we can really get an oxygen-enhanced MRI image, which can really show a better image quality. And also, during the delivery, more oxygen radicals can really kill more cancer cells, and then can really help the patient. So this paves a way opens a door. Of course, we are not reached there, but it opens a door to do a complete dose painting based on the biological of the target. So biological target volume can be defined with the help of an MRI, with the ADC values, with the PET CT, and then with CT scan, and then you can find out the areas where the patient might recur, or patient where the tumors which can really very notorious, where we can deliver a net dose, can be very well done with this biological guided treatment. So this is we have not yet reached there, but we are in the direction. Maybe you guys students are there. Maybe in your lifetime, definitely this will come, because now with AI booming up, with the technology going in the right direction, I think this is definitely maybe a reality in maybe at 5 to 10 years down the line, where we can really do a very high-end, high-quality radiotherapy with the help of biological guidance. Not only that, some people always ask me that how good is with the protons. Of course, proton is no doubt on that. Physics of proton is extremely good, no doubt on that. The Bragg peak is extraordinary, but the problem is that the proton has its own uncertainty. So there is an uncertainty, but whereas we don't have that. But if you look at the daily adaptation, there is no adaptation for proton. We have the protons adaptation. If you look at the soft tissue, they use CBCT, whereas now we do MRI, far better. No gating, where we have a continuous MRI. They give a lot of margin because their uncertainty is so much, they give margin, whereas the margins are less. So rectal dose with the prostate plans comparison, the MRI shows better. MRI guided radiotherapy has shown better survival, better lesser toxicity. The trials have shown better GU-GI toxicity as compared with the conventional SBRTs, whereas proton has never shown better that. So that shows that the proton is definitely no doubt on that, it's very good, but MR also has its own role and can match up to that level, where proton, it can really give you a better distribution not better distribution. It can give you a distribution which compared to the proton, the same patient goes for the proton, will also get similar one, but the advantage here is very advantage because of the gating, you have a lesser margin, so definitely toxicity is lesser. With that, I would like to thanks. And if you have any questions, I would love to answer that. Thank you.